And I'll have my panelists come up here and join me on the stage, please. Hello, hello. Okay, so we're going to land the plane here with some comments and thoughts from actual DPC physicians who are delivering this exceptional model of care to patients in their communities. With me on stage here, I have Dr. Kelly Parker-Mello, who is the founder of Tailored Pediatric Medicine, and Dr. Clint Flanagan, who is the founder and CMO of Nextera Health, and Dr. Jeff Davenport, who is the founder of One Focus Medical and the president of the DPC Alliance. Each of these physicians brings a very unique perspective to this discussion that I think makes it very interesting. And I'd like to start by having each of you introduce yourself and tell us a little bit about why your perspective is unique. Kelly?
Thanks so much, Sara. Thank you for having me. Again, my name is Kelly Parker-Mello. I'm a primary care pediatrician out of Portsmouth, New Hampshire. And I think pediatrics brings a little bit of a different spin to the direct primary care space. It is beyond my dreams, if I can describe it that way. It's something that I think supports families and parents in a way that I never could have imagined. And I think it brings real community that we're lacking in other spaces. It's something that I've just seen really magically transform families. And I don't mean to sound over the top, but it is something that I've been amazed at the impact that this type of care can have when you're able to give someone the time and attention that they deserve and need. So pediatrics is definitely slightly different from family medicine, but similar in many ways.
Thank you. Clint?
Hi, everybody. I'm Dr. Clint Flanagan from the Boulder, Colorado area. I'm the Chief Medical Officer of Nextera Healthcare and founder. This is our 16th year at Nextera Healthcare, and I think it's important to call out who created direct primary care. A lot has been talked about today, but just to be clear, physicians created direct primary care. So this is a model of care where physicians who previously had worked in the fee-for-service insurance-based primary care setting saw the barriers and said, gosh, we need to get back to the most important thing, and that's people, our patients, and we need to have a model of care that supports that. So back in Colorado 16 years ago, we did not even know what direct primary care was. We called ourselves monthly membership medicine, and we wanted to take care of the whole community. We started with one clinic or so in the area. Fast forward to today, we have over 200 clinics in our Nextera healthcare community across 25 states. And it's been talked about a couple of different times today. The majority of the people that we take care of are employers. And I think if anything talks to the value that we provide in direct primary care is the consumer or the employer continuing to pay you. And what you find with direct primary care is it's very sticky. Again, I think why is it sticky? Because how many people need a primary care physician or clinician in America? Our bias is everybody. The challenge is most Americans are currently in a relationship where they are seeing their clinician or physician maybe once a year for a preventative exam. And in primary care, we like to do lots of prevention and proactive care. We like to talk to people about your lifestyle, your sleep, your nutrition, your exercise, your emotional health. And again, we're taking care of people. Contrast that in fee-for-service medicine, patients are transactions. And you have to see 20 or 30 a day, which is what I used to do. And then I used to work in the emergency room as well. A lot of times, about half those visits in the ER are not emergencies. People are just scared and don't know what to do. So they end up in the ER and end up with a pretty hefty bill. So again, thrilled that we have the opportunity here today to talk about DPC and this HSA circumstance that many of us have been working on for years and years. Specifically, the Direct Primary Care Coalition has been a tremendous champion, and after years got this across the finish line, which means that at least 60-some million Americans are going to be able to use their HSA to pay for direct primary care relationships. And even better, you're going to see employers that aren't going to have the hiccups that they've had in years past with regards to HSA and direct primary care. Yeah, that's the DPC bat signal that everybody should be getting DPC. Yeah, appreciate the opportunity to be on the panel with you all today.
Thank you, Clint. Jeff?
Thanks for having me. First of all, I want to point out, I don't think it's fair that I was put on this panel with these beautiful people. I just feel like the troll under the bridge down here with all of you guys over here. The beautiful Dr. Flanagan with the good hair. But joking aside, I'm Jeff Davenport. I'm a family physician from Edmond, Oklahoma. I've been doing direct primary care for 11 years now. And I also serve currently as the president of the Direct Primary Care Alliance, which is our national physician organization. Essentially we believe in physician-led, physician-owned care. We represent all of direct primary care, all specialties. We recently had a conference just this last weekend in New Orleans with the FAAFP and the ACOFP called the DPC Summit. And one of the first things I did was I said, if you're a family doc, raise your hand. If you're a pediatrician, raise your hand. If you're internal medicine, functional medicine, lifestyle medicine, if you're gynecology, if you're an ER physician. And it was amazing. I just kept going down the list and people kept raising their hands. And so this is not just a family doctor movement. This is all specialties. This is people in some specialties actually feeling like they're burnt out. Maybe the specialty isn't what they wanted. Maybe they went to medical school thinking they wanted to do primary care and were talked out of it. There's so many aspects to DPC that reach out to who we wanted to be as physicians. We need our good surgeon colleagues and specialty colleagues as well, but as Dr. Clint said, this is a physician-led movement, and this new legislative change, I think, will only feed the fire. And those of us in the conversation, I still want, as Dr. Clint said, I still want people to recognize that us physicians want to lead this movement because we're in the trenches taking care of these people. They are employees, but I call them patients. So I'm here to help, but I want to also be able to lead this conversation. So thanks for having me today.
Thanks, wonderful. Well, Clint, I think I'll start with you. So H.R. 1, the Primary Care Enhancement Act, aims to strengthen primary care by paying primary care differently and opening up that opportunity to pay primary care differently to more patients and more PCPs. And you're a longtime DPC physician, longtime DPC advocate and champion. And from your perspective, having grown a huge DPC organization over the years, how do you think this legislation is going to impact the broader healthcare landscape? Because primary care doesn't exist in a vacuum. And so when we give more high-quality primary care to more people, what happens to the healthcare landscape? What do you see?
Directly, maybe we'll spend $1 trillion less on the $5 trillion that we're spending. So if you think about that $5 trillion pie, imagine more of that money going back into employees' pocketbooks, more of that money staying with the employer. And so that is one answer. That may take some time. So as you drill down to the employee or the patient, getting better primary care will serve the patient in tremendous ways. It was talked a little bit about earlier. So many are used to maybe a once-a-year checkup with their primary care clinician. One of the panelists mentioned that it takes maybe 6 months in a zip code where they're at to find a primary care clinician and or get in. So maybe double clicking on that a bit, imagine we're spending around $5 trillion. The world's 5th largest economy is our healthcare economy, and yet it takes 6 months to find a primary care clinician on a fee-for-service chassis. If you want to see the good Dr. Davenport or Dr. Sara, I anticipate you could sign up for membership with them, and they likely would be able to get you in that week, maybe even the next day for a checkup. And that one checkup isn't like, hey, we'll see you and then see you next year. You may have heard people talk about direct primary care like a gym membership. So you and or your employer are paying that monthly fee, and it was talked a little bit earlier that engagement goes up significantly because most Americans on fee-for-service primary care chassis aren't having an awesome primary care experience. The access, the convenience, the connectivity is just not there. So we have education that happens at the patient level, at the employer level, saying, listen, we want you to come in, we want you to establish, and typically when you have a visit with Dr. Sara or Dr. Jeff or myself, that's usually an hour-long visit or so on that first visit. And we want to understand where are you at in your healthcare journey, and we want to do what we can to move the dial forward and reach optimal health, okay? Much different than fee-for-service primary care, where we're seeing a patient about every 7 to 10 minutes, and that patient potentially has a copay, and or if they have a deductible, they could be out of pocket for that total visit. In direct primary care, there is no out-of-pocket fee, there's no copay. So you're engaging, it's a different relationship than you had before with your United, your Blues fee-for-service primary care plan, and that physician has time to take care of you and your needs. And a lot of times those visits can be face-to-face, and we prefer that, but they're arguably about 50 to 70% of the primary care visits can be done virtually. So we all have, we call them technology stacks, or simply you can text your doctor or you can have an email chat with your doctor. Because again, we're not on that fee-for-service chassis where every visit needs to be in person and to get paid. The business model is different. And typically in our models, people say, well, you're in the healthcare business. We're in the people business. We just happen to do direct primary care, which is the business that serves those people, okay? So I think, number one, you're going to see significant cost savings down to the patient level as well as the employer level. Number two, we're going to move the dial, it's been talked a little bit about, on health and wellness for employees. When you have dedicated teams of physicians and clinicians taking care of your employees, where 90% of the healthcare needs can be taken care of by Dr. Jeff or Dr. Sara, you have a circumstance that's way different than what you're currently doing. Most employers in America are paying a premium for coverage. We encourage employers to say, listen, we're going to invest in our employees. What's the best way to invest in your employees on the healthcare side is to get a direct primary care membership, and then you're going to pay for coverage. Okay, so we're the care piece, people sitting up here on the stage. The coverage piece is for the catastrophes or for the big high dollar elective procedures. And then it was mentioned a little bit earlier, another piece of what we do day in and day out is precise care navigation, also understanding the plan design. So you have your quarterback doctor that knows where to send you for the MRI, which you're getting at a discounted rate compared to running it through a traditional PPO plan. Number one, let's say you've torn your ACL. Number two, he has diagnosed that, and then you now go see a surgeon, and imagine direct pay to that surgeon, bundled payment that happens directly from the employer, versus running that elective procedure through a PPO plan and going to a system where that facility fee is tremendously high. So kind of into the granular detail a little bit, but we obviously are really devoted to providing excellent care to you, the employee, but we kind of take that a step further and saying, hey, let's also try to do no harm to your pocketbook as much as possible, right? So guiding through a physician on the primary care front. And then that goes steps further, because for the things that can't happen on the DPC ranch, we're going to help care coordinate. And it's not some third-party bolt-on that you put onto a plan and pay a PMPM for care coordination. It's actually your physician healthcare team being aware of the plan design and making sure that we navigate to the right place, right time, right cost. So sorry, I think that was a long answer, but I had a short answer first.
Yeah, it's a long answer, but that's because there are so many ways that we impact the quality and cost of care. And, it's because we deeply understand how to help patients get the right care at the right place by the right person at the right time. And it takes a fully empowered PCP to make all that happen, to make it come together. And that's what drives, I think the $1 trillion you mentioned might be a conservative estimate, actually. I think we can cut it down even more than that, which, how powerful would that be? So Kelly, pediatrics is a small but mighty sector of the DPC community. I think I heard recently there are maybe 150 DPC logos or practices in the US, but growing. And this is an option that maybe many families don't know about or haven't thought of. And I'd love to hear from you. I mean, I've heard so many stories from my DPC pediatrician colleagues about how powerful this model is for the families that they take care of. And so I'd like to hear from you. How do you think HR 1 helps us give DPC pediatrics to more families? How is this going to encourage more pediatricians to choose the DPC model and more families to choose the DPC model?
Great question, Sara. So I view HR1 as being a platform to really shout from the rooftops about DPC. In my area, I was the first pediatric DPC in the state of New Hampshire. I'm the only one within an hour radius, and there are still quite a few people who don't know what DPC is. And so I think that this is a great opportunity to spread the word, to allow parents to understand that there are other options out there. Because in pediatrics, we have a lot of touch points with families. On average, I see kids approximately 12 times in the first year of life, and I'm lucky enough to be able to do home visits for the first 2 months. So one of my favorite parts of my job is getting to go and sit on a floor with a family and a new baby and show them how to swaddle their baby and when to be concerned. And really, pediatrics is all about anticipatory guidance, right? So if we can make our patients healthier, our population healthier, that's going to just directly affect our bottom dollar. Healthcare is so expensive, and a lot of it's the end of life, where if we're able to move the needle on the healthcare for children, I think that can have a huge impact on our society as a whole. And I also believe that this is a great way to empower our youth and our teens to have more autonomy. All the teens in my practice get the texting app themselves. So sure, the parents love to text questions and rashes and all kinds of, middle of the night questions about their new baby. But the teenagers are a really neat population that I've found are really jumping into this type of model to really feel like they have a vested relationship with their physician, teaching them how to reach out to the physician themselves, not just go to the walk-in on their campus, but to contact me. And because we use great technology like texting, they're able to text us in a HIPAA-compliant way and ask us questions, when they're far from home and their mom's not there, or maybe they don't want to ask their mom. So it's just a really unique way to follow patients through a lifetime from birth through young adulthood. And I think that this bill will allow us to have access to more patients, allow us to bring the model to families that never even knew that it was a possibility, just had no idea that this type of care even exists.
I'm so glad that you mentioned the teenagers. I have a teenager myself who has been in a DPC relationship with her PCP. Shout out Dr. Monica Salas. And that texting relationship that she has with her PCP, I'm not even sure she realizes how much she should cherish that, like how different it is from what most teenagers experience. The fact that she has that direct access to a doctor who knows her, who she trusts, who she can ask any question of, and mom doesn't have to be in the loop. it has been a game changer for her. It's really so remarkable that the challenges that this model unlocks for kids. What new parent wouldn't love to have their doctor come to the house instead of schlepping that newborn baby to the doctor's office with a waiting room full of a bunch of sick kids with snotty noses? Like, it's just incredible.
Yeah, it's really been interesting from a pediatric perspective because I knew all the new moms would love this, right? All the nervous parents. And I'm amazed at how many ER visits I save by just saying, please call me. If you think it's an emergency, just call me, because the majority of the time, they don't need an ER. They just need advice. And so being able to give that advice over the phone saves, I can't even imagine how much money in urgent care and ER visits. But then also the continuity of care, right, with those teenagers, with the young families, to have someone who's trusted, who they can go to and has known them for, X number of years is really an amazing benefit for all of us, and really why we went into medicine as physicians.
So powerful. Okay, Jeff, I want to ask you about, there are so many people across the country who, maybe don't have the socioeconomic resources or are in geographic areas that have limited primary care. How do you think HR 1 is going to unlock opportunities for those populations to address health disparities and provide access to this high-quality relationship-based primary care?
Yeah, so I was excited earlier. One of the panelists mentioned a statistic that was fascinating to me. Did he say 61% of people with HSAs live in counties where the socioeconomic status is lower than whatever the metric they were using? I mean, I had no idea. I mean, that's amazing to me. And so when I hear that that's the way it is right now, but with this law change, companies being able to offer this to some of their employees, I would expect that to continue to expand and even grow. And when you think about physicians, I can name McAllister and Ada and Duncan and Sealing and your friend, our friend, Dr. Bushman from Enid. I can name all these small towns in Oklahoma. You guys don't know these are small towns. But I just named not Oklahoma County, where Oklahoma City and its suburbs are, not Tulsa County, where Tulsa and the suburbs are. There are already DPC docs in all of those towns. And I can just, we have DPC docs in small towns all around the country, but I continue to see more and more independent physicians opening up small practices in small towns. My friends like Dr. Clint from Nextera, I don't even know how many branches that they have at this point in time. But there are corporate DPCs as well for physicians who don't want to open their own practice. But a law change like this will create opportunities for more physicians to open up mom and pop shops. Myself, I'm a mom and pop shop. Now my town is 90,000 people, so I'm not in a small town. It's my hometown, so I'm back home. But what an opportunity for small town America to have a doctor be able to practice in a model like this and have more expanded opportunities for a family that may not be able to just pay straight out of pocket for it with post-tax dollars, but maybe their company can provide an opportunity for them or pay for them, and that just creates the supply and demand, right? That just creates more of the demand. And something for a very long time that we have all been fighting is, first of all, nobody likes change, especially physicians. And so trying to convince some physicians that this is the way to go, they're like, oh, I don't know, that's kind of different. And yet one of the fears besides just a change is, how am I going to create my patient panel? I have to actually go find them. They don't just pick me off the website from the insurance company more. So how can I sell this product? How can I create my patient panel? And they've been afraid of that. And this is just one more opportunity for us who are experienced and already doing it to explain to them, look, there's going to be people looking for you now. You just got to put your name in the phone book. Do we use phone books still? I just aged myself there. But anyway, you just got to open your shingle and get out there and pound the pavement and find the companies, find the employees, because there's just going to be more and more opportunity for patients to be able to find this type of care and use it. And especially in the small towns. The big towns already got a ton of options. The small towns, this is the type of thing that is a game changer.
Wonderful. Well, I'll present a question to any or all of you who would like to take it. So looking 5 to 10 years in the future, pull out your crystal ball and think about down the road the impact that HR 1 will have on primary care and the future of primary care and healthcare and patients in this country. What role do you see DPC playing, and how do you think this is all going to evolve?
Just looking at you. So 5 to 10 years from now. So if we go back just a little bit, years ago we were maybe 1% of the marketplace. I think data coming out of the American Academy of Family Physicians, I believe we're around 10% or so of the marketplace. And so signing of HR 1 into law is going to be a catalyst for growth. You heard Jeff talk about it a little bit earlier, as well as prior panelists. So you'll have more employers with deductible plans and HSAs incorporating direct primary care into the benefit plan, and the innovative plans surround. So DPC is at the center of innovative plans. So they surround other things, let's say specialty care, imaging, pharmacy, et cetera, but you put direct primary care at the center. So passage of HR 1 will be a catalyst for more of those plans. We work a lot with advisors, brokers, and consultants because we work with employers. And time and time again, you'll hear a broker say, gosh, it's, quote, illegal to have a deductible in an HSA plan. And those are strong words, and we don't quite think it was illegal, but the short is now those brokers, they can't pull that answer out. So you'll see at least more of the, let's say, innovative benefits advisors incorporating direct primary care into plans, which will, it'll be great for their book of business, because what happens when you incorporate direct primary care into an employer plan is they don't leave. They stay on for years and years and years. And so 5 to 10 years from now, we'll see more DPC physicians, clinicians in a variety of zip codes across the country. Some of them will open up their own practice in small towns. Some of them will join groups like Nextera Healthcare. Specifically on that front, I've hired about 10 physicians in the last 6 months or so. And the common thread with these physicians that I've hired is A, they've been practicing for at least 10 years. B, they've been in health systems that are really creating a lot of moral injury for these docs. They are overburdened with administrative tasks and pecking their computer for payment as they're on this fee-for-service chassis. And those, let's say, PECs are only becoming more. So we pull these physicians out of these systems. One was a 66-year-old that retired because of the pressure in the last 20 years he's felt from this system. So he is reinvigorated and now will start working for us 3 days a week in Kansas City in his retirement. Phenomenal doctor, 30 plus years of experience. And so one of the lanes that we have is just rescuing these physicians from the systems they're in. A lot of employees don't necessarily realize, but when you're on that PPO plan or that deductible plan on that fee-for-service primary care chassis, that clinician that you're seeing is really overworked and underpaid and has an administrative burden that's tremendous. Like, do you really want to be seeing that guy or gal? Or do you want to see Dr. Davenport or Dr. Sara or Dr. Kelly? Right? So you're paying for a clinician, your employer, and that's an experience. And I would argue that direct primary care is the best experience in primary care you're going to get in this country. And that's coming from 25 plus years of being in medicine and seeing what is there. So it works for patients, direct primary care works for employers, and it also works for communities and physicians. And so we're pretty excited about the future in 5 to 10 years from now. I mean, again, we started with 1 clinic, now we're around 200, so who knows, maybe we'll be around 1,000 or 10,000 or, but we're not going to be at 200,
Aim big.
Do we have a couple minutes?
Go ahead.
Or knowing me, do we have like 19 minutes? I'm pretty gabby. I want to paint a picture. I hope that our employer friends, legislators, let me paint a picture. Imagine an employee of any company who is empowered by these law changes to be able to pay for a physician directly from the patient. This is what my dream would be in a situation like this. Let's say that patient, AKA employee, actually loses their job. Maybe they move, maybe something happens, heaven forbid they go through a divorce or a family. Things change, so they lose their job, but maybe they get another job, but they don't have to change their doctor because the doctor isn't specifically directly contracted with one company or one agency or one whatever, but somehow we all, and it's going to take the powers that be, the employers, the businesses, to figure out how to empower that employee to choose their own doctor. Because that's one of the things I hated about the fee-for-service insurance system was when I lost a patient just because they changed their job. Or I gained a patient and the patient was like, well, I loved my other doctor, but my job's changed. And I was like, oh, great, no pressure there. I got to be as good as the other doctor, right? And so I would hope that we figure out a way to empower the patients. I don't know if it's a card or we just put money in their account or whatever, but when they choose their doctor, the doctor doesn't even know who the employer is or if the employer is paying. To us, it just looks like the patient is paying us to take care of them. That's what my dream is, so that all of the mom and pop doctor shops don't get lost in the shuffle of having the opportunity to take care of these employees. And the employees have to choose from a specific brand of an office.
Well said. Well said. Any final words, Kelly?
I think I just want to add that right now, DPC pediatricians are less than 1% of pediatricians out there. And so in 5 to 10 years, I'd like us to be the 10% that you guys are now. And hopefully we're following suit and can serve many more children.
Can I say something about pediatrics? I know that a lot of, I'm not an expert on employers, but a lot of employers, like, they pay for the employee, but then there's kind of various aspects of care for the family, right? What an opportunity for employers to attract good employees, even if they don't cover the entire health plan, whatever that looks like for the child, but what an incentive. Hey, come work here, and we're going to give your kid a direct primary care doctor. Wow. What an opportunity for employers.
Well, I want to thank Primary Care for America and the American Academy of Family Physicians for hosting this event, and I want to thank our panelists here and all of our other panelists for joining us, and all of you for joining us today. This has been, I think, a really informative and powerful discussion, and we're excited to see where this goes, and I'm going to hand this back to Sean.
Thank you very much, Sara. I want to thank you for joining us on this program. I especially want to thank our 3 moderators, Sara, Michelle, and Jay, for bringing together expert panels to share information on the Primary Care Enhancement Act and the wonderful opportunities we have to extend comprehensive and continuous primary care to individuals and families across the country. To learn more about Primary Care for America, you can visit our website. To learn more about the DPC Alliance or the DPC Coalition, please visit their websites as well. And please come back as we continue to offer information about how we can advance a healthcare system built on the importance of primary care through our collaboration here at Primary Care for America. And in closing, Sara, I personally want to thank you for hosting our event today. We appreciate your expertise and passion around this particular issue. Thank you so much.